Welcome back. By now, hopefully you've taken enough time to work on your formal interpretation of ABGs, because I'm about to change up your terminology on you. All right, some people call this advanced ABG interpretation. I really don't like that name. It implies that it's harder, and it's really not. I like to use the term descriptive terminology, because rather than a formal interpretation, we're going to look at a blood gas now and just describe what's happening. I'll show you what I mean. Let's take what we would consider a normal patient. And by normal, what I mean is having no underlying lung pathology. They don't have chronic lung disease. Okay, so this is a PaCO2 and this is our bicarb, just like we've been doing, okay? So we look at this blood gas and we call this normal, right? Normal pH, normal CO2, normal bicarb, it's normal. Okay, the real name for this is normal acid-base balance. Okay, so normal acid-base balance. Pretty easy, all right? But in clinical practice, as respiratory therapists, we have another set of normal blood gases that we have to talk about. And it's the blood gases associated with patients that have chronic lung disease, such as COPD. So I'm going to draw a line here. Our normal patient's going to be on top. Our chronic lung disease patient's going to be on the bottom. So okay, so this is a classic COPD blood gas. And so let me tell you what I mean when I say descriptive terminology. Because if we were to interpret this formally, you would tell me this is a fully compensated respiratory acidosis. And that's absolutely right. But in clinical practice, we don't always use that terminology. So let me step you through why we use the descriptive terminology. All right, so if we look at this, see how this CO2 is elevated? All right, anytime the CO2 is elevated, you can safely say a person has ventilatory failure. So right now, just looking at that CO2, I know this person has vent failure. All right, so anytime that CO2 climbs above typically 50, we typically call it ventilatory failure. But with COPD, what happens is this person's CO2 climbs gradually over time, okay? Months, weeks, years, okay? The CO2 is climbing gradually, which allows the bicarb to elevate also, which stabilizes or compensates for our pH. And so I know this process has happened gradually because the bicarb has changed. So while this is ventilatory failure, it is chronic ventilatory failure. These people live everyday life like this. And as a respiratory therapist, we need to know that because we're going to be seeing patients in chronic ventilatory failure all of the time. All right, so I hope that makes sense because we're going to talk about things that can happen from these normal conditions. All right, so let me erase this and let's talk about a change that can happen. So for example, we can have a person with normal lung physiology, okay, no underlying disease, and let's say this patient has a narcotic drug overdose. And when that happens, we expect that CO2 to elevate, right? Because they're not breathing, their respiratory center in their brain is depressed, they're not breathing as much, so CO2 elevates. When CO2 elevates, pH decreases, but this has happened so suddenly that this patient has not had time to compensate. And I know that because the bicarb is normal. So when we look at this blood gas, this person has ventilatory failure because that CO2 is higher than it should be. They're not ventilating, ventilatory failure. But this has happened quickly, So quickly, in fact, that the bicarb hasn't had enough time to elevate in an attempt to compensate for it. So we term this acute ventilatory failure. All right, so it's a more description of what's going on with the patient rather than formal interpretation, because you really can look at this blood gas and say this is an uncompensated respiratory acidosis, and it is. But in clinical practice, more often you're going to hear a therapist say this patient is in acute ventilatory failure. All right, pretty easy. That makes sense, right? All right, remember we have a chronic lung disease. This is this patient's normal. But this patient that has COPD that lives in this situation, they can have a narcotic drug overdose too, right? And so when that happens, their respiratory center in their brain is depressed, they don't breathe as much, and CO2 climbs. And anytime CO2 climbs, pH falls. And this drug overdose we're talking about, it's happened suddenly, right? And so suddenly that the bicarb hasn't moved in an attempt to compensate for it, because this 30 is this patient's normal. And so when I look at this blood gas, this is acute ventilatory failure. All right, I know that this is how it was, and they have had an acute condition on this. But they started out in chronic ventilatory failure, right? All right, keep that in mind, because this is going to always be termed on top of chronic ventilatory failure. So what we have, this blood gas shows an acute ventilatory failure on top of their chronic condition. So acute ventilatory failure on top of chronic ventilatory failure. Sometimes that's a mouthful, right? So sometimes we say acute on chronic ventilatory failure to describe this. If you want to sound really fancy, you can say acute ventilatory failure superimposed on chronic ventilatory failure. Superimposed just means on top of the chronic condition. Okay? But again, what we're describing is what's going on. They live in chronic ventilatory failure, so we know that this is going to be on top of that chronic condition, and it is an acute ventilatory failure because the CO2 has risen abruptly and the pH has dropped. But it's happened so suddenly that their bicarb hasn't shifted from their normal to stabilize the pH. Okay? So we have two different conditions now. We're using new terminology. We've learned chronic ventilatory failure, and then we've learned acute ventilatory failure on top of chronic ventilatory failure. Right? So let's do one more change just to make sure we have all the new terminology straight. All right, here we go. So let's take this person with the absence of chronic lung disease, our normal patient. And let's say our normal patient suffers from anxiety attacks. And for whatever reason, they have had an anxiety attack. Okay? So their respiratory rate increases. Anytime the respiratory rate increases, typically what you see happen is that CO2 being blown off. Okay, lots of minute volume goes in there, removes the CO2 from the alveoli, from the bloodstream, so CO2 drops, and anytime CO2 drops, pH climbs. All right? So if you look at this blood gas and you were to interpret it formally, you would tell me this is uncompensated respiratory alkalosis. And that's absolutely right. But if I'm going to talk about this from a clinical standpoint, this person is hyperventilating, okay? Because that CO2 is low, and a low CO2 is called hyperventilation. All right, so hyperventilation. It is an acute situation, and I know that because that bicarb has not moved in an attempt to compensate for this. So we call this acute hyperventilation. Now, sometimes we like to throw an extra word in there to make it confusing. Some people call this acute alveolar hyperventilation. And don't let that confuse you, because that CO2 transfer happens at the alveolar level. So acute alveolar hyperventilation. All right, that's pretty easy, right? We're just describing what's happening to this patient. All right, our COPDer that lives in chronic ventilatory failure. Okay, they live in chronic ventilatory failure. Okay, this COPD patient can have an anxiety attack. And when they do, their respiratory rate is going to increase and they're going to blow off their CO2. So this patient, maybe when their respiratory rate starts increasing, their CO2 drops to 37, and when CO2 drops, pH increases. All right, but when I look at this, I know this is an abrupt change in status because look, they started out with a bicarb of 30 and the bicarb hasn't moved. So this is an acute hyperventilation because the patient has dropped their CO2 from their normal down to 37. This patient is hyperventilating. It is an acute condition because their bicarb has not moved in order to compensate for it. All right, so we call this acute, and you can put that alveolar term in there if you want. Acute alveolar hyperventilation on top of chronic ventilatory failure. All we're saying is this is a COPD patient that's hyperventilating. All right, so acute hyperventilation on top of chronic ventilatory failure. Or you can be fancy and say acute alveolar hyperventilation superimposed on chronic ventilatory failure. It means the same thing. All right. I want to explain to you why we use this newer terminology. Because what's going on is we are truly describing a hyperventilating state. And you can tell from this normal, this patient's hyperventilating. If we don't call it that, if we just took this blood gas and didn't pay attention to their underlying lung disease, and we just used sheer numbers to interpret this, we would call this a, we have an alkalosis here. I'm just going to step you through it. This is a normal CO2, 35 to 45, right? And a high bicarb. You would actually call this an uncompensated metabolic alkalosis. In formal interpretation, that's absolutely right. But when you say metabolic, you're blaming it on the kidneys. And this is not a kidney problem. It just really isn't. What it is a person that lives in chronic ventilatory failure, so on top of chronic ventilatory failure, acutely hyperventilating. All right, so you may have to go back and watch this lesson multiple times because it is a little bit rough of a transition, but always start out with your 2 sets of normal, okay? Hope to see you back soon. We're going to roll oxygenation in this and then we're done with ABGs.